Welcome to Big Plants, Big Ideas. We're back again with another episode, and this time I got my friend Joe Weber with me. He's a PT, been in healthcare for a little while, and he's going to be interviewing me about some of the different aspects of going to Seattle U for nursing school and kind of what that means and just some of the self-reflection that comes with that.
Yeah. First off, man, congratulations.
Thank you.
You know, it's been a long road, and it's been a pleasure kind of watching you through this journey. Super excited for you for the next chapter.
Thank you.
Yeah. So as far as Seattle University, their specific mission statement, how do you feel like that has kind of influenced your nursing practice?
So I think one of the things that Seattle U actually does really well, and they kind of hammer this one in, is educating the whole person. I think it's interesting having been a transfer student and therefore like a post-bac, because you kind of come in with a lot of life experience. So you kind of have some of that already, but what they do really well is just hone that in and say, not only are you going to be a nurse, but we're going to examine every aspect of humanity and how that applies to nursing.
Yeah.
You know?
Yeah. Do you feel like on some of your clinicals that you've kind of been able to adapt that to like the patient populations you've been working on?
Yeah, absolutely. I think, so we get to go through each and every population, right? Like pediatrics, we get to go, well, we missed OB because of COVID, but we get to go through all these different populations, and then right now for my final practicum, I'm in the ED, which deals with everybody, every single type of population possible, from marginalized populations to vulnerable populations, elderly, pediatric, to those with less resources. And the cool part is you have to think on your feet in a way that you can best serve them. And obviously I think sometimes in those high mental health pressure situations, you have to, we get trained to de-escalate, but it's different than actually de-escalating.
Right, right. Yeah, I remember like you were taking some courses that were just like heavy on ethics, and I think it was like U-Core classes and things that were like kind of outside of nursing specifically, but like definitely related as far as kind of like treating that whole patient. What were those like U-Core classes that you took?
So the cool part about being a post-bac is that you don't actually have to take as many. You only have to take 2. Mm-hmm. And I say that, but I'm sure they were all enriching for those that had to take more. My 2 were healthcare ethics and Jesus and liberation class. Mm-hmm. And I am not religious in any way, shape, or form, other than like if that's something that works for you, do it. That's great. But for me, it's never been something. It was when I was young, and then we quickly kind of fell out of it as a family. Yeah.
Kind of similar path myself.
Yeah. Okay. So it's I told the professor day one that I was like, not a deal, not a thing. Yeah. And he was like, great. Yeah. Let's just see let's see where that goes throughout the course. So I will give props to him for that. And it was really interesting just to see how that continued to take shape. I think, as I was talking about, like marginalized populations or vulnerable populations, homeless populations. I think for me, my perspective shifted a little bit. I think we have the privilege of working with those people as a nurse. When everyone else says you, we get to go, come on in. Like, what do you need? Like, let's get to base level and find what you need. And that class, I think I called it Jesus class, really helped me. It helped me get there and reminded me that like not only do we get this instruction as a healthcare professional, but it's also just like it's very worldly.
Yeah.
How did it change for you, or like how? Let me ask it this way, I guess. So how did religion stop or change, and then how is it now for you?
Yeah. So very similar like kind of upbringing as you. I was raised Roman Catholic, and we went to church religiously for no pun intended. For like maybe up until like 3rd grade, and then I'm not sure exactly what happened, but it kind of fell out. And then when I got into college, I kind of started getting into it a little bit, kind of toeing in again. And never dove back into it like I had when I was a child. But I think the biggest thing is just any religion, it's sense of community. I mean, the amount of support that you get from other people with, if you're going to church together and you meet those people on a regular basis, and if somebody's struggling and kind of helping them through that. So I think that there's certain concepts. I'm not very religious, but I do try to take those aspects of like community into things, and like kind of helping each other out and that sort of thing. Yeah,
that's beautiful.
Yeah.
How do you feel like that applies to your practice as a clinician? Or does it?
Yeah, I think like, I guess the just first thing that popped in my head, I'm not sure how great of an example this is, but you can't always choose your community. So right now you're working at Issaquah ED. You can't choose who's going to come in, but you got to treat them with the same amount of compassion, and try to remove any biases. And I think that's also like part of community, right? Is there's like the community that you're involved in. It's not perfect, but it's trying to help each other out and kind of get through that. So I guess that's how I kind of approach that.
Yeah, that's a good answer. I was thinking about that yesterday or today, actually, in which one of the cool things about being at the small hospital is like it feels a little bit like pride, like this my community, my house. It feels really interesting and kind of fun to say. I thought of it in the context of all the COVID patients we've been seeing, and I feel this overwhelming sense of duty and obligation to like educate the community and help these people in the community. And I don't even live there. Right. I live 30 minutes outside of that hospital, but it's interesting. I love the way that you bring in that community aspect, because even though it's not technically my community, I'm part of that hospital community.
Right. Yeah, and I think especially like with COVID, I my last travel assignment was working in Crescent City, and it's 7,000 population, and you get kind of this close-knit feel where you're kind of in the trenches with people, and because it's a smaller community, kind of everybody like kind of knows each other, and so basically the point I'm trying to get to is very relatable for sure. So as far as like nursing goes, I kind of look back at my like PT career, and there's definitely been like notable mentors along the way, and like kind of these figures that have like really influenced who I am as a physical therapist, or how I treat as a physical therapist. And what sort of like people have like kind of stick out to you?
I would say almost dovetailing. Truly, I think when you're in the trenches, you build this interesting camaraderie, and that's our GoPro going off. When you're in the trenches, you build this interesting camaraderie, and you can't help but bond with those people, even if they're the ones teaching you things. So I think the most experiential people are the ones that I've had the most experiences with, or maybe there's a better way to say that, but I would say my preceptors, especially this last one. I spent 160 hours with her for 8 weeks, so it's a nice crunched, intense amount of time. I think the other one was in my med surge rotation, in which I was just with this. I ended up getting placed with this one gal like 4 times, and she was incredible and brilliant. And I mean these words when I said it to her, still do. I told her at the last day, I was like, if I could be half the nurse you are, like I'll be fine. And so I think while all of our professors could have been those people like X amount of years ago, if I was with them learning from them at clinical, I think they all teach us a lot. My advisor for sure has always had my back, and I think it's the cool thing about nursing, I guess if I could sum it up, is it sounds like the culture's changed, but the culture in which I've been introduced to is pay it forward. Like, we don't eat our young anymore, and it's a lot of like, this is hard, this is mentally and physically exhausting, so what if instead we helped each other out and had the idea that like there is no stupid question, because if you feel like you have to preface it with that, your environment, I think, is already corrupt, because it's not our ego is actually not the thing on the line, it's the patient's safety that's on the line.
Yeah.
So I think some of my nursing heroes are definitely my clinical advisors or my preceptors. You can't help but like admire someone who's just like boom, boom, badass practice, and like, right on every single bullet point before you're still 10 bullet points behind, and they're already thinking about the next 10 ahead. But I appreciate like their patience, their kindness, their instruction, and their willingness to meet everybody, but especially my preceptors to just say, well, all right, little duckling, like, come on, we're gonna go and we're gonna teach you now.
Yeah. Yeah, it kind of seems, and you kind of summarize it right at the end there. Yeah, it does kind of seem like, as far as those people who have had the biggest influence on you, it's been, like, not only just dialed in their skills, but also approachability and, like, willingness to, like, kind of give back to, like, those who are, like, kind of coming up. So that kind of, like, leads into the next point, like, as far as, like, leadership styles for, like, nursing leaders, what sort of like leadership styles do you think are like most important, like leading into your future career?
I think that I'm a big fan of servant leadership. Having been in some management positions before, I think the moniker, I'm not going to ask someone else to do something that I wouldn't do myself.
Sure.
Especially in nursing, like, I think my favorite example is like, hey, like we have to do a couple, not just one, but a couple enemas on a patient in room so-and-so, and the charge is like, you guys look like you're in the weeds, like, can I do something for you? And and that's, I think, what it's about. I don't think she ended up doing the enema because I needed to learn how to do it, which was fine, but it was, I think that was the biggest thing. Like, when your charge nurse is busy, how do they respond, right? Yeah,
that's huge, because that sets the environment for everything.
Yeah.
Like, if the charge nurse has a certain attitude or is not approachable, or, I've worked in hospitals where, all right, this is the week that the this charge nurse is on, and it's just like, you're not going to get much help, and things are not going to be run as smoothly, and then you got other weeks where it's like, I'm a physical therapist, but, I can't find the nurse for patient in room 3A, and the charge nurse is there, and I'm asking them a question, and they kind of go out of their way to like answer that question, educate me a little bit more, and that's been hugely important, because now it just changes the dynamics as far as like the approachability, like you were talking about.
So you felt that all, like that ripple effect.
Yeah, even
all the way
being outside of the profession. I mean, you're kind of like, when you're in the hospital, you're working as a team, right? So, and honestly, like, the nurse is almost like the quarterback. Like, they're gonna know that patient better than anybody else, just because like they're in it. So they're a huge resource, and if they're not approachable, then that makes my job a lot harder, makes patient care not as good.
I love that example, because it's so indicative of like, hey, healthcare is a team sport. And if you want to be a jerk, you can, but like,
it's not helping anyone.
It's a really cool perspective to hear that's been your experience.
Yeah, as far as like that, leadership wisdom, that like, upcoming nursing students, what would you like be sharing with them as they begin their journey in nursing school? So like, kind of thinking back, so you've come like full spectrum, right? Like, you've gone through the full experience of starting nursing school, changing careers, and now you're kind of at the end of that, where you're about to now start nursing, and some of those leadership wisdoms that you learned along the way, like, what sort of things do you think would be most beneficial for like incoming students?
That's a good question. It's, if I could summarize it, it's a question with a lot of depth. I would say that you're gonna freak out, but don't freak out. There are things put in place where you can't kill someone as a student, so get that out of your head now. I think it's like as soon as you start nursing school, you're like, I'm responsible for people's lives, and your hand is very much held. I think it goes without saying, like, yeah, work hard, right? Like, how do you not kill someone is you make sure you know what you need to know.
Yeah. Which
I am learning very quickly. Like, I won't know that until I'm a year in of my actually nurse practice. But they also aren't going to give you assignments, and I say that like a year because they're not going to give you assignments that are in over your head. If you're charge nurses, like that's part of their role is to make sure that the acuity matches the skill. So work hard. You're going to worry, but don't worry. And I think community is like the biggest thing that I could say that is most important. You literally, as you said before, you've seen me from start to finish, from redoing prereqs all the way to like I'm done in a week.
Yeah.
You've seen me at some highs, you've seen me at some lows. I think people that are willing to celebrate the highs, that's really important. Especially if you, as you know, like I'm pretty bad at, I will brush things off. I can't take a compliment. So like if someone's like, shut up, you actually did well. Like that's good. You need that. And I think it's important to have people that you can fall back on or pick you up when you're down, or say like, I guess I think the biggest thing for me, because I was talking to someone who's thinking about doing nursing, I was like, you're going to lose relationships. You're going to lose friendships. You're going to lose time. You're going to lose your mind. Because you want to do well. And that's kind of where it comes in, like, hey, do the work, but you're not going to kill anybody. But like when you always have that kind of nagging thing in the back of your head saying like, don't mess this up, because if you do, you kill someone. Like you're just forced into this arena of like, I can't fail.
Yeah.
So I think having a community to bolster that is so important. Just in terms of like surviving, and I kind of come back as you will lose all these relationships, and that's okay. But what comes through the woodwork instead is friendships that are golden. Mm-hmm. If someone gets pissed at you because you're busy, for self progress, for self goals, for healthy self desires, and they get mad at you about that, it's like, well, should you really be with that person? So I think for me, it's just get a great community and you'll learn who they are quick, and then don't let go. You don't waste your time, because you won't have any, on relationships or things that you're unsure matter.
It's funny you say that, because so you started that with saying that it's really hard for you to like accept compliments and accept help, but then talked about how important it is to reach out to your community when you need help, right? Like it is going to be challenging, and it's quite the undertaking, but knowing that you've got a support system and using that support system effectively, to kind of get you through like those tough points.
Yeah. How is it we've talked a little bit before, like off camera kind of thing, but what I felt like I knew you in like undergrad experience that was crazy. Joe's a straight A student working hard, same kind of mentality of, well, I have to get A's because it's not, it's not about the grade at this point, right?
Yeah.
So how do you feel like that, especially, I know your master's part of your doctorate, was harder than the undergrad stuff. How do you feel like you got through it, and what were some of your takeaways that you would pass on?
Yeah, it wasn't. So undergrad was really difficult because it was high competition and everybody was kind of out for themselves, which then with PT it was different. It was like, all right, we're all in this together. We're going to crank hard. I'm sure like some of your nursing cohort colleagues or nursing student colleagues are some of your like good friends now, because you're just in it all together, right? And you're just like trying to help one another out to like be the best like you can be when you come to that graduation date. And I think that speaks huge to like, you know, the difference between like my undergrad and my grad. Were very different. I think also like I was a little bit better at studying by the time it came to like grad school. Had enough like experiences that then led, and you know, I had a lot of like clinical experiences that then by the time I got into grad school it was a little bit easier because I had like my athletic training background where I was able to like kind of go through that. So I think in healthcare in general there's like a big push for evidence-based practice. Where does that come in with like nursing and like your treatments?
I think it gets preached a lot in nursing school. There's a lot of like you do your own, we call it EBP. We do your own EBP research and projects, and you learn that like that's what you should be thinking about every time. It's not. It's very actually liberal artsy. Like if you think back to college, like always question why. And I think the same. That's kind of what we get taught, at least applies to nursing practice. And the common example that always gets used is like, well, why do we scrub the IV hub for 5 seconds, or 10 seconds, or 15, depending on what like your you know your locations policy is, what the research says. And it usually always errs on the side of like safety and precaution. And so I think, for me at least personally, I would love to be part of like a research group. I think that's part of what makes healthcare great. It's like we're always trying to learn. That's part of what CEUs are, right? Here's the new emerging evidence on XYZ.
Right.
The one we're working on now, I'd actually like to really pursue, which is the lack of education and experience in assessments for darker skin tone patients. It started as like a respiratory assessment focus, and then we opened it up saying that there's overall just inequity in education about how we assess darker skin tone patients. Yeah,
like a lot of, you know, similar kind of thing with PT, right? Like erythemia is like a big thing for like, you know, all these different signs, symptoms, like, or I guess just signs. And you know, darker skinned people, like I remember like in PT school, one of our like African American students was like, hey, like I'm not gonna get that response, like how does that present for me? And like the professor really didn't have an answer. Wow. I mean, this is like, you know, 5-6 years ago, but yeah, it's just interesting. Yeah, where those things are leading, and I guess that kind of leads into the next question as far as like this past 2 years has there's been a large like social awakening, and so current events like kind of reflecting on past current events over the last year, 2 years, how has that shaped your educational experience?
I mean, it has to, right? COVID obviously is like shot or a lot. Well, I shouldn't say that. I think a lot of people would say that COVID has made our education very, very different, and I would agree. We were lucky. Some schools didn't get to do in-person practicum clinical. We did, and that makes all the difference for a hands-on profession. But you know, I think I'm not a remote learner. I'm a hands-on learner, and I knew that going in. And then when we had to do remote learning, you know, like I check out after an hour, and it's hard to stay focused. And it's kind of like what we talked about before, like where that feeling of like I'm in charge of someone's life, like I can't not learn this.
Yeah.
So then it just becomes different. It's like, well, I guess I'm spending more time just doing rote memorization, and that's not fun. It's necessary. I think the other side of it too, though, is like, well, Zoom fatigue. Everyone talks about that. That's super real. Mm-hmm. And so it played a factor in a big way. I think the social and racial injustice, civil unrest side of things, it's like, as a middle-class privileged white male, it's like I'm so grateful to have had at an unfortunate cost, something to say, like, wake up.
Yeah.
You know, I think as much as I would like to say that I was, like, neutral and fine and great, I think it was a good reminder, too, that, like, well, don't ever stop improving.
Yeah.
And whatever that is, in this circumstance, it's you know, racial and social injustice.
Everybody has biases, right?
Right.
And it's I think, like, recognizing those biases and what things, like, contribute to the biases that you have, like what sort of upbringing you've had, past experiences, things like that lead you into preconceived biases, but those can also, like, be moldable and be changed based on education, experience, things like that. So yeah, definitely, like, kind of keeping those, like, kind of keeping that radar and, like, being able to recognize, like, those flags kind of going off, right?
What do you feel? How do you feel like it changed for you in your practice?
Well, it's interesting because I feel like on a personal level, I feel like I didn't get the typical COVID experience, right? So I continued working all through COVID. I didn't have to do any telehealth. I didn't have to do any remote learning, nothing like that. So not that things kind of, like, work went on as usual. It definitely didn't. You know, I was working with COVID patients. I was working in a rural hospital that was heavily conservative in the sense that there was not a lot of following of CDC guidelines, and it was very frustrating to kind of go through the early stages of the pandemic when a lot of things were political. And that kind of affected the health and safety of patients and staff and things like that. So that was eye-opening and frustrating. You know, I've always lived in a place like Seattle, Portland, Eugene, places that tend to lean left, and this was the first place I was working at that leaned right. And just being kind of, like, exposed to different outlooks, different mindsets, different approaches to different things. You know, I'm sure you'll kind of experience that as you go through nursing. And it kind of comes back to, like, how we were talking about earlier, where there's a human across from you, right? And so they might be saying certain things, doing certain things, and believing in certain things that are vastly different than what your core values are. But at the end of the day, you got to kind of put that aside and take, like, a 30,000 foot view, right? Of you know, outsider's perspective. Sometimes I try to think about, like, if I'm treating this patient and I'm gonna do this approach, communicate this way, apply this intervention, what would someone who was just reading through the transcript and just had, like, the documentation, how would they interpret that? Because that's kind of removing your bias of seeing that individual and creating those internal biases that come along with things. So sometimes I feel like that's a little bit helpful. But yeah, I mean, as far as, like, you know, your unique experiences with going through COVID and the systemic injustices, you know, Seattle was definitely one of the like, leading cities that was having a lot of kind of movement towards reform. How has that kind of enhanced your leadership roles for nursing and kind of promotion of health equity?
I think we get taught. I think it's obvious until you have to think, or unless you think about it. It's like it's a background noise, right? Saying, like, well, obviously be equitable, right? But it's a greater awareness, and I think and I've honestly loved it because it forces me to question myself more and ask myself more, I'm having like your classic implicit bias type of chain of events. I'm having a reaction. Why is that? How do I feel about that? What are my own thoughts before I go into this room, or before I respond to what this person's saying? I think it's forced that hand a little bit more, which I like because it challenges me to be more equitable, more driven to give great care no matter who, what, anything, whatever comes through that door. If it's a dog, I'm going to give it great care. If it's a cat, if it's a human, doesn't matter what that human looks like, I want to give it great care. I think, my history as a bartender, it's a lot of dealing with idiots. And so, I've luckily had a lot of practice with, someone says an off remark and you're like, the difference is that in a bar you can go, cool, get out.
Yeah. Right.
In healthcare, you're like,
propofol.
20 mgs? Oh, you said 10. Are you sure you don't want 20?
Yeah.
Right. So it's just you have to catch yourself, and I think kind of what I like. Actually, you know what? I feel, and I don't know if you feel similar. Every time I put on scrubs, it might be different when you put on an ATM, but Joe works here physical. Joe works at blank place physical therapy clinic. I feel it's almost to me like the sense of duty is hey man, this is a privilege, don't mess it up, do your thing. You're gonna get mad at some point and that's fine, but the whole point is the scrubs and your training and your education remind you that if someone's being unhappy and they're mad or upset or sad, you're trained on how to deal with that, and it's remember empathy. It's I don't think I was an empathetic person necessarily before nursing school. I think I was okay. On a scale of 1 to 10, I was maybe a 4 or 5.
Yeah.
And now I'm much more well, I think my favorite quote is negative behaviors are unmet needs.
Yeah.
Right. So it's okay.
Yeah, and there's a lot of interaction. We kind of talked about this before. There's a lot of interactions that lead up to your interaction with that patient. And so it might be something that's completely out of your control that they're acting this way. And sometimes, it's just a matter of kind of reading that individual and, being that kind of changing factor, right? So the benefit that you've had with bartending, and I think about this all the time, what sort of skills do you develop with what you do majority of your week, right? So bartending, physical therapy, nursing, we are constantly having so many interactions with people. I'm really good at just reading somebody right off the bat, right? Figuring out what sort of things interest them, motivate them, irritate them, right? And so you get really good at reading those sort of things and adjusting your communication and interaction with them, which is not always the easiest thing. Sometimes I'm kind of struggling with trying to figure that out. So it's kind of you get a person and sometimes you got to give back to them, and then all of a sudden they're oh, you're okay. I like you. But then some people, you do that and it's going to go really wrong really fast. So I think that those soft skills of what are our past experiences, and this actually kind of flows in well to that evidence-based practice, right? So evidence-based practice is not just research, right? It's a triangle. So it's research, evidence-based research. It's clinician experience. So what are your past experiences with different patients, and also your personal past experiences and things like that. And then the third part of the triangle is the patient experiences, right? And so it's kind of tying all that in together. I think, like, honestly, everything just comes down to communication and, like, interaction with one another. Obviously, making sure you have the hard skills of applying a certain intervention, like you were talking about algorithms earlier. You know, if you screw up an algorithm, then, like, clearly then you're going to have a negative outcome. But if you can apply the right algorithm with the right communication strategies based on your own personal experiences, that then will, like, lend well to that patient experience, then that's going to provide the best outcome. But that's just a very difficult thing to, like, kind of read and figure out what's going to work best for them.
And so let me ask you this: do you, having some personal experiences recently in the ED where it's very fast, you have these, like, boom, boom,
it's almost
boom.
harder for you. I get a whole hour with a patient.
Well, right, that's fair.
Well, like,
we're just gonna stare at each other. We gotta talk this out.
Yeah.
So I have found it's just like bartending, and then to the point where, like, I'm trying these one-liners, and I think you phrased it extremely well in terms of, like, what you have to constantly adjust. And so my question for you is, knowing that my own experience has been, like, you try a one-liner, whoa, that wasn't it. You know?
Yeah.
Like, oh, ooh. Or sometimes people are like, yes, this nurse is my favorite. So my question for you would be, I guess, twofold, as per usual. What are a couple of your favorite one-liners? And then what are the first 3 steps you take when you're meeting a new patient mentally?
Alright, my favorite one-liners are... I know this off the top of my head. It's tough to remember because I only remember the second part of the one-liner. Because I say the joke, and then I say, and you can tell I've never told that joke before. And oh God, what is it? I don't know, like one, you know, a lot of times, like, we're having to change positioning, so I'll be like, okay, can you go ahead and lie down on your back? And they lie down on their stomach. I'm like, oh, your other back. Yeah, but I mean, that's not a great example. That's not the one but that's just the first one that kind of came to my head. Second part of that question was what?
What are the first 3 things that you're thinking? And I'm thinking almost like assessment route. And we can bring it back to EBP. We can bring it back to social injustice. But when you're meeting a new patient for the first time, like, what's going through your head? I know it's probably a little different in physical therapy. You're probably watching gait. You're probably watching, like, whatever their injury is, like, how are they moving? How are they talking? So let's get past those, like, classic ones. What goes through Joe's head? What is Joe looking for?
Where are they at with the injury? As far as... where are they at with along the healthcare course? Have they seen multiple providers? Am I the first person seeing them, the second person seeing them? How is their interaction with the doctor? What have they done up until the point from the injury till now? Because that not only gives me a good idea of, you know, injury progression and tissue adaptation and things like that, but also, like, if there's somebody who's like, yeah, I saw this doctor, they gave me these exercises, I was doing them religiously, like, 3 times a week, and, like, I'm still in the same boat, or it's getting a little bit better. That gives me an idea of, like, their intrinsic motivation. How are they going to do with overall, like, outcomes, like, later in the course of care? Or if there's someone where, like, yeah, I saw this person, they, like, brushed me off and, like, gave me this, like, PT referral. Okay, maybe we need to, like, give them a little bit more self-confidence, right? So there's, like, what are the there's self-confidence, relatedness, and autonomy, which are like basically like intrinsic. There's a certain term for it, but there's these three principles that like each individual needs these sort of like psychological things met. And so, yeah, I guess like just trying to get a good read off the patient off the bat. Like you might be asking one thing, but and it helps you with your like overall nursing interventions, but you're at the same time getting a read for somebody's personality traits and like how they react to certain situations. You know?
Yeah. That's interesting. I'm gonna steal that. I think it's more of like a long-term care question, but
yeah,
it's a great opportunity to be compassionate. It's a great opportunity to gain some trust and let them know like, hey, I'm wherever it is that you are at. Like that's where we're gonna start. That's where I'm on your side. I think it's a little different with ED because usually you're seeing it at the very beginning.
Right.
So it's a great question to also keep in mind though, as I'm hearing you say, it's like, oh well, you know what? Like that sets a tone, right? They come to you a year later, 6 months later than from when they saw me.
Yeah.
And so it's, well, how is there a possibility to set this off on the best foot forward? It's kind of cool to hear your perspective, knowing that like the timeline is very different.
Yeah.